Good afternoon, everyone. Welcome to Undue Burden, a conversation with Shefali Luthra, class of 2014, about life and death in post-Roe America. My name is Marcia Eli, class of 1980, and the co-chair of the Pembroke Center Advisory Council's Programs Committee. On behalf of the Friends of the Pembroke Center for Teaching and Research on Women and our co-sponsors today, the Brown Women's Network, the Division of Biology and Medicine's Office of Belonging, Equity, Diversity, and Inclusion, the Sarah Doyle Center for Women and Gender, and the School of Public Health, I'm so happy to welcome you to this Family Weekend program. Founded in 1981, the Pembroke Center's research and teaching explore social change and how questions of difference in gender, sexuality, race, class, religion, and more affect our thinking and our world. Since its founding, the Pembroke Center has enjoyed and been strengthened by the support, engagement, and advice of a broad and dedicated community, the Friends of the Pembroke Center. The Friends are alumna, parents, friends who support the mission of the center and their work, and has helped the center impact students, scholars, members of the public, researchers, both here at Brown and beyond the campus. The Friends Advisory Council organizes programs such as this one to connect communities, both alumni and wider friends with the center. My co-chair Ryan Grubbs is here as well. So I am entirely delighted to see so many people, and I'm going to tell you now a little bit about our guests. Shefali Luthra has reported on national health policy for the past decade, most recently at the 19th. Her coverage of abortion rights has been cited in congressional testimony and Supreme Court briefings, and in 2023, she received an Online Journalism Award. Luthra's writing has appeared in the New York Times, the Washington Post, NPR, and more, and she is the author of Undue Burden, Life and Death Decisions in Post-Roe America. She lives in Washington, D.C., and if you have a copy of the book and you would like her to sign it, I know she'd be very pleased to do that later at the table. Dr. Ben Brown is the Mimi Peachy Assistant Professor of Obstetrics and Gynecology at the Warren Albert Medical School of Brown University. And one of the initiatives that he oversees in that capacity is the Women's Reproductive Health Fund, which you have a flyer about on your chairs. I'm really happy to say that Mimi Peachy is here this afternoon, and if you'd like to hear more about that work and all that the important initiatives that are happening under the Women's Reproductive Health Fund, please talk to her at the reception afterwards. Dr. Brown is chief of the section of complex family planning and an attending physician in the Division of General Obstetrics and Gynecology at Women and Infants Hospital of Rhode Island. He is board certified in obstetrics and gynecology and in complex family planning. Dr. Brown's clinical interests include high acuity obstetrics, complex abortion and contraception care, and management of early pregnancy complications and ectopic gestation. His research focuses on family planning policy analysis using quantitative methods and an ethics lens. So I'm going to tell you a little bit about how things will go this afternoon. First, Dr. Brown and Shefali will speak for about 45 minutes, and then we're going to open up the discussion for your questions and answers. Again, welcome to this Family Weekend program. And now it's my pleasure to hand it over to Dr. Brown. Please help me welcome them.
Thank you very much, and thanks to everybody for joining us today. I think this is going to be a really timely and an important conversation. I think the first thing that stands out just in terms of talking about the book is the power of narrative. For those of us who exist both in clinical research and advocacy spaces, we often our initial reaction when we want to kind of advocate or comment about policy is to talk about the numbers, and we know that numbers don't often drive home the reality of a policy or of the way that the world works, the way that narrative does. And so that strikes me about the book. And I wonder if you can start off just by talking a bit about how you came to this project and how you framed it.
Absolutely. Sorry, I am a little bit shorter than the microphone, so all right, I think that should sound better.
You got it.
But yeah, I started thinking about this book because I'd been covering abortion for quite some time. I covered it in 2013 as an intern in Austin, Texas, writing about Wendy Davis's filibuster, and then as a reporter at the 19th, where when Texas passed its 6-week abortion ban, SB 8, they immediately sent me to Texas and said, see how people are being affected. And I had this experience there that just really shaped how I think about abortion journalism, which is I was in the clinic. I met a young woman who appears in the book, only very briefly, and she told me about being there to try and get an abortion and meet this 6-week deadline that the state had just imposed. And she was very scared it wouldn't work. She was about to spend every cent she had if it hadn't worked, and she would have to do this again. And I looked at her, and I thought about the situation that she was in and thought about, we had talked about music, we had talked about TV, and we also talked about this very hard thing that she was going through. And I understood in that moment how easily I could have been her. And having that experience and seeing her in front of me, I wanted to give other people that feeling. And so I really worked very hard to try and center people as I covered abortion. But by the time we got several months later to Roe v. Wade being overturned, it had become also clear to me that this was a national story that many reporters were covering largely through the lens of politics. And I wanted to give people a chance to think beyond simply how does this matter for elections, how do we think about how candidates talk about this, how does this come out on the campaign trail, and what does this mean for people? What could this mean for me? What could this mean for someone I love? And so the book, if you get a chance to read it, and I hope you do, it follows people. It follows a few main characters, but it also follows many other people throughout the book just talking about their experiences trying to get abortions. And I think that matters for what you said and what we were talking about earlier. People understand this issue when they can see someone and think, that could have been me, that could have been someone I know, that could have been someone I love. And it takes abortion, which has for so long been this very abstract issue that I think has been used as a partisan issue, a political issue, and something that actually is a story of healthcare and human rights and gender equality, which is what it is.
Yeah, I really appreciate that lens, and I think that is such an important framing to put on the broader policy and political conversations, because we talk about it in the abstract, and the reality is that there are people providing the care, people who need the care, people who are denied the care, and all of those stories are wrapped up in every one of those votes, right, for around a given policy. I can only imagine that there were a lot of stories. I can only imagine that you're sitting with a lot of stories, some of which maybe didn't make it into the book, and I wonder how you made decisions about how to structure the book.
It's a good question. And actually, when I first came to the book, I really thought we were going to follow one person throughout the entire narrative. And I had this realization that actually wouldn't work, because the story of abortion is too complex and is too big and too broad for any one person to carry throughout a book. And so instead I thought, well, let's think about the different people who get abortions and the different circumstances under which they get abortions, and how can I tell that story in a few discrete but fleshed out narratives. And so there are 4 main characters the book follows. There is a young teenager who wants to get an abortion and cannot, and has a child as a result. She lives in Texas. There is a young mother. She's in her early 20s. She travels out of Texas to get an abortion because she knows she can't afford another child. There is someone who has a medically complex pregnancy and needs to travel out of state to get comprehensive reproductive health care and learn about what her options are, and she can't do that where she lives anymore. And the last of those main characters is a trans man in Florida who gets an abortion while navigating both the restrictions on gender-affirming care and also on abortion. And I chose those people very deliberately because we do hear a lot about medically complex pregnancies, and those are very important because I think people outside of the medical field, people not as, as well-knowledged as you, don't realize how complicated pregnancy is and how often it goes wrong. So that's a very important story to tell. But I think a lot about how the data shows us that the people who get abortions are largely not those cases. They are more often young mothers, people in their 20s, often women of color, people who know that they can't have another child for economic reasons. And so I knew we had to have that voice in there as well. And then I do think it's important that if we're talking about abortion bans, to see who are the people who are affected when abortion is actually banned, and what does that look like in reality? How does that change your life? And then including a trans voice really mattered because I really see the attacks on abortion and the attacks on gender-affirming healthcare and trans rights as deeply connected. And I don't think we can talk about one without the other. And so as I built out those narratives, I think they really complement each other. They happen to be from a handful of states, Texas and Florida, which are the biggest states to ban abortion. But I think the diversity of voices is really, really critical because it highlights that the fall of Roe has a universal impact, but also an unequal one.
Yeah, and I think that in my head ties to something that you draw out in your intro and something that a thread that you weave through the book, which is Dobbs is this moment of rupture, right? But we know that abortion was inaccessible to a lot of people, progressively so over the years leading up.
Absolutely, yeah. And the book it structurally starts several months before the Dobbs decision. And first, we get into the history, and there was this long effort that began, after Roe came down, the anti-abortion movement very quickly began to try and get it overturned, to try and restrict abortion. But really in the 2010s, became very smart at passing restrictions that led to clinics to close. Missouri and Mississippi are two states that come to mind where they only had one clinic even before Roe was overturned. But the book then starts in Texas with that 6-week ban that I mentioned, which took effect September 1st, 2021, which was many months before the Dobbs decision, but really highlighted that the abortion legal protection framework that many of us relied on had gotten so fraught, so weakened at that point, that it actually could be almost completely circumvented by lawmakers and politicians who were smart enough to figure out what they were doing.
And I wonder if you can maybe speak a bit to the way that intersects with some of the, with an intersectional lens on access to care, right? We think about these intersecting barriers.
Yeah, exactly. And what we saw was abortion had grown harder and harder to come by for years, and especially in the final years leading up to the Dobbs decision. And that didn't mean you couldn't get it, but that meant you had to drive much further. It meant maybe you do have to leave your state even before the Roe decision was overturned to get an abortion. Maybe you needed to find childcare, find a car, someone to help you get there, to pay for a hotel. If you lived in a state like Missouri, you had to make 2 visits to a clinic separated by 72 hours, see the same doctor on both of those trips. Mm-hmm. What it functionally did was meant by the time Roe fell, abortion was very, very hard to get if you were poorer, if you lived in rural communities, if you lived far from, a robust medical infrastructure, if you were a minor. All of these things that already make healthcare hard to come by, that can put you at greater risk for worse health outcomes, for worse economic outcomes, also made it harder to get an abortion, which then, of course, when you can't get an abortion, you also can have worse health outcomes and worse economic outcomes. There's a real cycle that occurs.
Yeah, absolutely. And I think that's been something that we've seen on the research side over years as well, right? That we abortion is essential. People who need abortions really need abortions for all the reasons that you articulate, right? And so people work really hard to be able to access the care they need, and healthcare workers, healthcare systems work really hard to try to provide that care. But at a certain point, eventually enough barriers put in your way, you'll be unable to access care.
And it's something that I think is so interesting because one thing that does come up is the immense hardship people are willing to undergo to get abortions. And there was this study that I cited in the book that just has really stayed with me ever since I read it. And the researchers talked to people about what they did to afford their abortions traveling out of Texas. And there was this one family that talked about how they just didn't buy food for several weeks, and so they only ate the scraps in their home, and they had a dog, and they couldn't buy dog food, so they would feed their dog whatever was just not good enough from those leftovers for the dog. And it's just, we see people overcome immense hardship and get abortions, and that's why the number of abortions hasn't fallen in the past 2 years. But what we don't see is that that's because people are navigating very extreme circumstances and being put into economic and social and financial hardship that they don't have to be, simply because of laws that we as a society have chosen or have had chosen for us to be in place.
Another part of that dynamic that comes up for me in your book is the experiences of people who are trying to help people access care. And I think, we talk a lot in the popular narrative about the work that doctors and nurses do in ensuring access. And as one of the people who does that work, I think that's important work. But some of the stories that really stick out to me, even if some of them are quite brief, are people working in practical support groups and abortion funds and people doing all the various jobs that it takes to help keep abortion services available, which strikes me from your writing. I wonder if any of those, what are your reflections on those, and tell me a little bit about your experiences working with people providing care?
Yeah, and I think that many people learned a lot about abortion funds very soon after the Dobbs decision, because there was this real energy, donate to an abortion fund because they will help people get over their abortion bans and travel out of state to get care. And they are remarkably resilient, very effective organizations. They are also very small, and they are largely volunteer staffed. Maybe they have a couple of employees who are trying to send all these people to another state, navigate all the funding they've gotten, while also figuring out what is legal, what are they allowed to do, and are they at risk for some kind of criminal prosecution, especially in a state like Texas with a very litigious attorney general. And one thing that you and I talked about when we were preparing for this event was how vast and how tenuous the abortion care system that now exists is. We have seen providers, we have seen physicians, nurses, and people who work in these abortion practical support groups like funds do basically everything in their power to help people overcome these bans that I think it's worth noting are some of the most extreme in the world. And there's a limit to what people can actually do. Like, the money is running out. Abortion funds are cutting their budgets because the donations are drying up. At the same time, we are seeing even more states pass bans. More states have banned abortion now than had a year ago, than had 2 years ago. And so as the distance people have to travel gets further and further, the journey becomes more expensive. Everything becomes more expensive because that is the nature of economics. At the same time, the resources are no longer there. And I just think that this is something I couldn't fully get at because we're still in the early days of living through this moment in history. But at a certain point, the system that we have in place can't hold. And I don't know when that comes, but I think it comes soon.
Yeah, and I think that's certainly on the care provision side. That's something that we worry about and do our best to avoid and to strengthen systems around. But yeah, I think that's a fear for everybody involved in the care for sure. You bring up something in that comment that I want to delve into a little bit more, which is the way that the fear of legal consequences works for people providing care as well as people seeking care, which again comes up a lot in the stories in your book. Tell us a little bit more about that and how you saw that operating in people's lives.
One thing I was really struck by when I interviewed people, largely patients getting abortions, was they really did not know what their rights were. And so the people who got around abortion bans did so in two ways. They either traveled out of state for an abortion and then came home, or they had pills mailed to them and took them at home, which is medically safe, it's very effective, it's nice to have, a doctor that you can talk to on the phone to make sure everything is going okay. Complications are very rare. But the biggest threat that people really felt was they were afraid of criminal prosecution. And abortion bans do not explicitly target people who are pregnant. That is something that the anti-abortion movement has not done because of the political consequences. It would be very, very unpopular to do that. But people don't know what their rights are, and you can't blame them because their rights feel like they're changing every day. You actually don't know what the laws are 2 states away from you or 3 states away from you or 1 state away from you, let alone in your own community. And so I kept hearing from people, I've traveled out of state, but I don't know if this is illegal, or I've ordered these pills, but I don't know if I'll get in trouble. And I often was the one to tell them, you won't, because what you've done is not a crime. But that's also one of the reasons why many people wanted to share their stories. Very few wanted their full names in there because they don't know if their rights will change, and if at a certain point someone might target them legally or in other ways, because at some point getting an abortion could be even more criminal than it is now.
And that's such a rich area that you just alluded to, which is the why for why people wanted to share their stories. Can you talk a little bit more about that?
Yeah, I was talking to a mentor about this recently who has been covering abortion for much longer, like 50 years. And one thing that she said to me was when she first started writing about this, people did not want to talk about their abortions. It was very, very hard to get someone to go on the record and share their story. And there's a reason for that, which is abortion has been very stigmatized by our society. People don't feel like they can talk to someone about it. You may know that your friends and family support abortion in theory, but that doesn't mean they support it when it is you in practice getting one. But something has really changed, I think, in the post-jobs landscape, which is this real sense of like duty and mission that people felt that I found very inspiring and very moving. They shared their stories because they hoped that someone else might feel less alone, because they felt so alone when they were navigating this very scary, uncertain process. And they thought, well, if someone else knows what I went through, when they go through it, they'll at least know that I was there with them. One woman I have been thinking about a lot lately, she comes up later in the book. She traveled from Missouri to Washington, D.C. to get an abortion because of a fetal anomaly that meant she couldn't give birth to a healthy pregnancy. And when we spoke, she said, well, I haven't told anyone my name when I share my story, but since your book is coming out not right away, you can use my first name. And I said, great, that sounds wonderful. And so I included her story. And then more recently, she put her story in a TV advertisement for the Missouri ballot measure around abortion. And I was just in such awe that she had found the strength to talk about this really hard thing on TV and see her face and her name in her living room and in many other people's living rooms. And I think that really highlights this journey that a lot of people have gone on, where they see that telling your story can have real consequences and it can affect public policy. And so this is very hard to do. It takes a lot of courage, but they really want to because they're hoping it will make us live in a better, fairer world.
Yeah, I think if there's a kind of unequivocal point of inspiration, I think that's a contender for it, for sure.
Yeah.
Have you seen any? I guess, how have you seen the role of narrative, whether from the folks in the book or as you've been covering this kind of from a journalistic perspective, how are you seeing narrative play out in the kind of current policy conversation?
It's very interesting, I think. And I'm going to use an example that this may sound very tangential, but I promise it's leading to a point, which is Melania Trump recently had her memoir come out, and she talked about how she supports abortion, including abortions later in pregnancy, which has been a real sticking point for a lot of Republicans, a lot of abortion opponents. And she said, well, abortions later in pregnancy usually happen because of very sad circumstances. And that's something that people hadn't really been saying a few years ago because the stories weren't out there about most of the people who get abortions later in pregnancy. But we are seeing more stories out there. People are talking about, well, I needed this abortion because I found out after 15 or after 20 weeks about these medical complications, and I needed to think about what to do and then raise the money and then grieve and then travel to one of the 3 clinics in the country that would see me. Or we are seeing more polling now showing that people support abortion at all points of pregnancy because they have seen all the different stories of people who have been affected. And what I think is just really striking about the Melania Trump example and also the polling data in general is shifts in abortion opinion are so rare. And the fact that we are getting them now is a real testament to the fact that people have seen and read and heard the stories of people who have suffered the alternative and who can tell you this is what it looks like when you don't have access to this, and this is how it affects you from a health outcome and an economic outcome. One thing that you and I have also talked about is diversity of storytelling. And I do think we have a ways to go there because most people who get abortions, as we mentioned earlier, They are not wealthy. They are largely working class. They are largely young mothers. They are largely women of color. And those aren't the stories we hear the most. We largely do hear stories of upper middle class women, largely white women in medically complex pregnancies, which are very, very important stories and also not the only stories. And so I am very hopeful that as especially a media industry, we will shift to be more inclusive, because we are the only ones who can really change the agenda of what people talk about. But I am actually optimistic that we'll get there.
I love that, and I think you have objective data to suggest it, right? As you say, like if we see changes in that are that make sense as a response to the proliferation of narrative and people telling their stories and explaining what's happened for them and what abortion has meant to them, why wouldn't we expect the same as we see a broader diversity of those stories coming out, right?
Exactly, and I do think that one thing that is really interesting is we can look at which voters in the upcoming election say they care about abortion. It is largely women. It is often young women, and it is also women of like a variety of racial backgrounds. And if I were someone coming up with political strategy, I would say, well, we should tell stories from all of those backgrounds so that people can all see themselves in this and feel represented and understand why this issue matters to them. So I think there is a narrative argument for doing this. There is a fealty to the truth, and also at some point, a pragmatic reason to talk about the variety of people who are affected by abortion bans.
Taking that to kind of another, expanding on that a little bit, one of the things that again we were kind of talking about and thinking about how to communicate around the kind of the messages and the experiences in this book was we talk a lot, I think, about the impact of abortion bans on the people in the states where abortion is banned, but we know there are actually meaningful effects nationwide and across state lines, and some of that comes out in the stories in your book. Do you want to talk at all about that side of the coin?
This was, for me, one of the most important reasons to write this book. When I was pitching it in very early meetings, I remember hearing an editor saying, well, I won't be affected by this because I live in New York. And I just was like, that's not true. And there are so many reasons for that. There is the obvious people traveling. As you mentioned, we have seen people travel to Rhode Island and to Massachusetts and to Maine and to all parts of the country because they can't get abortions in their homes anymore. And as a result, we have actually seen very real resource strains in states with legal abortion, very long wait times in places like Colorado and New Mexico and Illinois, where abortion is legal and protected, but they have become safety nets for other places with very strict bans. But the other thing that I do think we need to talk about, other than the potential for a national abortion ban or national restrictions, is the immediate and medium and long-term impact on the healthcare system. And we were just talking about this before the event started, but we do have data showing that doctors who are affected by abortion bans, so especially people who want to become OB-GYNs, in some cases, people who want to be oncologists, per some recent data I was looking at, are deciding where to do medical residency based on the state's abortion laws. Because why would you want to practice in a state where you won't get the full scope of training? Why would you want to potentially work in a state where you can't give people the full health care that you know is appropriate to them? And the other thing that I think about when looking at this data is most people who are becoming new doctors, and especially OB-GYNs, are also women. And so many of them, when they look about where to practice for residency or for their careers, are thinking about, well, what options will I have? And so as a result, we are going to start seeing real changes in where people practice medicine in the short term and long term. There is a real risk that I've heard from some people who study this where they worry about long-term shortages. And we already had shortages in a lot of essential healthcare providers, including OB-GYNs and family physicians. And that could be exacerbated, which would not only affect the Texases and Floridas of the world, but would affect all of us, no matter where we live.
Absolutely, absolutely. And I similarly, I was just at a conference this past weekend where I was talking to students from all over the country who are interested in OB-GYN and family medicine and pediatrics and want to provide abortion care as part of their care. And it's hearing the stories of people trying to make the decision of, hey, I'm from one of these states where there's where abortion is banned, and I grew up here, and I love my family, I love my community, and I want to serve this community, but I have to make this choice about, like, do I leave to get the training, knowing that there's a good like a lot of people stay where they train for their practice, and so there's a chance that if I leave, am I then gonna not be coming back to serve this community? And that's can be heartbreaking, right?
It really, really is. And on the flip side, right, let's say you do get your training in one of these states where abortion is illegal and you can't be trained in abortion, and as a result, you may not become as proficient as you would be in miscarriage care. You may stay in that state. You also could eventually practice somewhere else, which does mean that there is a world in which fewer doctors are as practiced as they would like to be, or as we as a society would like them to be, in doing something as essential and basic as caring for people getting miscarriages, because it's the same kind of medical care.
Absolutely. Yeah, and we certainly see that. I think any of us who teach abortion care to clinical trainees, I would actually say to a person, we have all gotten an email or a phone call or a text at some point from somebody that we trained, being like, hey, just want you to know that, like, I was the only OB-GYN on labor and delivery last night, and someone came in and they needed an emergent D&E procedure, and I was the one who could do it because my colleagues weren't trained. And those are the things that are like that's why I get up and teach in the morning, right? Like, knowing.
And that highlights like how important your work is and the work that all of you do when you are able to be trained in the full scope of healthcare. But that's also like, that is so tenuous to know that, like, what if that person had been sick that day? What if they had a family emergency and no one was there who knew how to provide a D&E? Then what happens?
Right. Yeah, and that's a really scary possibility in my mind, right? We're seeing increasing data out of states where abortion care is banned of people having bad outcomes, where they have more blood loss than they would have had somebody been able to intervene sooner to provide a D&C or a D&E. We're seeing a lot of largely so far anecdotal, but I think unfortunately we're likely to see larger scale data in the coming years and months that suggest that we can see the harms, we can measure the harms when people don't have consistent and equitable access to care.
I think that's a really good point also, because we do talk a lot about mortality data, like infant mortality and pregnancy-related deaths, but there's a lot to be said for morbidity that shortens your lifespan, right? And if you are delayed in getting care for pregnancy loss because someone is waiting to make sure you are sick enough to qualify for a medical exception, that can have long-term outcomes. That can mean that someone eventually has to get a kidney replaced. That can mean infertility. That can mean something that ultimately will shorten your life and your health. And even if that is not directly a death caused by an abortion ban, it is the quality of someone's health and well-being materially and irreversibly harmed.
And the other piece of that in my mind too is that if you think about the number of bad outcomes that lead to a death, in a pregnancy-associated death from something like blood loss or a delay in care, for every person who has the most severe outcome of a death, there may be a number of people who experience one or more of those intermediary outcomes, and so it's the canary in the coal mine on some level. When we see, hey, we're seeing that people are losing blood that we know they shouldn't have to be losing, we worry that then mortality follows too.
Which is very reasonable.
Yeah, and devastating that we're having to think about demonstrating that impact of policy, to be sure. I think I would be remiss not to point out that policy and politics are intrinsically linked, and we're obviously weeks away from a national election, and I wonder how, recognizing that none of us has a crystal ball, I wonder how you foresee the impact of the elections on abortion access, this policy landscape.
I laughed when you said weeks because I was like 11 days.
Fair.
11 days, but I think it's very clear already that the fall of Roe v. Wade has had a huge impact on the election. I was talking to someone who works in polling recently, and they joked that if Vice President Harris wins, it will be in large part because of an abortion. And that's a joke, but it's not a joke, because it has been a major part of her campaign focus. We have also seen that when she became the nominee, more voters said it was one of their top issues, and it's also something that they trust her on. There was recent polling that showed that for women under 30, I believe, abortion is their #1 issue going into the election. And that hasn't happened before. The idea that abortion is now more important than the economy for people who support abortion rights as opposed to oppose them is quite transformative. I don't know if that is enough for the vice president of an unpopular incumbent to win, but I do think it is a really marked shift from how abortion was treated as somewhat of a sideshow, a niche interest in every presidential election leading up until now. And I do think that if Harris wins, we will see people talking about abortion as a major reason why.
And I think that's coming from an advocacy space. Prior to this election cycle, I think we really had not seen a lot of national politicians even say the word abortion.
Joe Biden famously did not say the word abortion very much. And I mean, Vice President Harris, right? I mean, she is the first sitting president or vice president to have gone to an abortion clinic. That's a really significant shift from where we were even a couple of years ago. And I do think that goes back to what we were talking about how this has been something that has been really siloed, really stigmatized. And there are very real efforts that I think are important to make this a mainstream topic that we understand as worthy of our collective and total attention.
That is actually maybe a really good segue to what I'm thinking about, which is I'm reflecting on the fact that for reasons that I think are self-evident, a lot of the things we've been talking about are really heavy and really intense. And one thing that I see in providing care and in making sure that people are able to get the health care that they need when they need it, is that accessing care is for many people an act of liberation, an act of joy, an act of love. And I wonder if we can maybe talk a bit about some of the things that you have seen and learned and maybe written about that are those kinds of aspects of this care.
There's a woman in the book, one of the 4 main characters, whose name is Angela. And Angela is the young mother. She lives in Texas. She has a small boy, and she needs an abortion. And so she travels to New Mexico to get it. And she gets her abortion, and she comes home. And we spent a lot of time talking about how hard the trip was for her financially. It was very difficult. She used basically all the money she had. She was trying to save up to go back to school, wasn't sure if she'd be able to, didn't feel like she had really anyone she could talk to about this because her mother did not support abortion, and they had a very fraught relationship that she was trying to repair. And over the course of reporting this book, I spent a lot of time just really, really worrying about Angela and being like, God, I hope she's okay. And then when I was finishing it, I was like, well, how are you doing? How have things been over the past few months? And it was the best news I've ever heard. She had gotten a new job. She had made plans to go back to school, found the program she was going to do. She was going to study to become a nurse. And the best part was that she and her boyfriend, then now her fiance, and their son had moved into a bigger home, which was something they had felt they couldn't afford to do, but they had somehow saved back the money. They had this home. They had a bedroom for their kid, which they didn't have before. They were able to paint the walls the colors they wanted. And all of this was possible for her because she didn't have another child, and she had the freedom to actually try and conceive of a life that she wanted and that was right for her and her family. And I just found that so powerful and so inspiring that someone can go through so much and navigate these really arduous obstacles that were put in front of them, and then at the same time access healthcare that really does just open a whole new world of possibility to them. That's really profound.
Yeah. And I think that's the if working with a trainee who then one day emails you at 3 a.m. like, hey, thanks to working with you and all the other people, I just provided this life-saving care to somebody. If that's the kind of the why of being a clinical teacher, I think that sort of story is the why of providing the care in the first place, right? Because it's so impactful for people.
You really did change someone's life, and they wouldn't have been able to really participate in our society as a free, equal citizen without that.
I think that's a pretty outstanding place to maybe pause and see if there are folks who want to share questions from the audience.
Thank you so much. I'm Aletta Margolis, class of '89, and Shefali, you spoke a little bit about changing hearts and minds through storytelling. And my question is, strategies you've identified or used to reach the people, like probably a lot of us here don't need to be convinced to support abortion rights. And probably the people buying your book are people who are already supporting abortion rights. How do you reach the people who you're trying to reach to hear the stories to help them understand the issue in a deeper way?
I think one thing that is really important for us to also consider is that most Americans do support abortion rights. And so there are a minority of people whose minds will not be changed on this issue. And that's just sort of par for the course. We have to accept that as it is. But many more people have a much squishier sense, and when they hear more stories, they actually will think, oh, well, actually, I do support this, and this makes sense to me and my life and my family for all these reasons I didn't consider before. We were talking earlier, I actually did an interview yesterday with someone who told me that he had that same experience himself as an interviewer over the process of reading the book, of coming to think about abortion in a new way, in a way that felt more foundational and fundamental, because he had seen so many people. And so I think the answer to your question is that you can't reach everyone, and that is something that we have to accept. But what you can do is provide as many stories from as many perspectives and as many places and people as possible, because eventually, I think by the sheer magnitude of that storytelling and by getting that as many places as you can, eventually people will finally see themselves in someone, even if it's not the person you thought they would.
I'll add to that while we're waiting for someone else to ask a question. That's exactly what we were just starting to talk about this right before we started. There's a group of folks at University of Michigan. Lisa Harris is one of the key researchers there, and Brown residency alum Jenny Villavicencio, who've done a lot of work on that. And I think consistently what they've done a lot of studies on communications around abortion, and one of the really consistent through lines has been finding the narratives where people can empathize and understand how see themselves, see their loved ones, and so yeah, that's what the data say. In addition to just the human experience of talking about these topics.
I am grateful to be validated by the data.
100%,
That's very helpful.
100%, yes.
Thank you for your talk. I had a few questions that come about from listening to the presidential and vice presidential debates, and the discussion about we want to revert to what the law was under Roe v. Wade. Can you describe what that was and whether statutes that have been enacted in more progressive states since Dobbs are reflective of Roe v. Wade? And then on the other side, the discussion about attempted abortions where the fetus is born and what happens then, and maybe this is more for the doctor, does that occur? I mean, I just was surprised when that point was raised in, I think it was the vice presidential debate. So sorry for the multiple questions, but appreciate any
I can start
thoughts.
with the laws, and then we can talk about the medicine. Roe v. Wade, in its text, well, there's actually two cases. There's Roe v. Wade, and then there's Planned Parenthood v. Casey. And so Roe protected the right to an abortion in the first 2 trimesters of pregnancy. Then Planned Parenthood v. Casey came along in 1992 and shortened that time frame a bit. And so what it said was the right to an abortion is protected in this country until fetal viability, which varies from pregnancy to pregnancy, is determined by a doctor. Usually it is in the 22 to 25 week range, but again, it's variable. States could add some restrictions on abortion before that point if they wanted to, but they could not impose an undue burden on someone trying to get an abortion. That didn't mean that states were not allowed to be more permissive. And I mean, there are states that allow abortion through all points of pregnancy that allowed that before Roe was overturned under the Roe framework. Washington, D.C., where I live, is one of those places. And so that's what the Vice President Harris is talking about. That's the law that she has endorsed, is restoring a national right to an abortion up until the fetal viability point. And then if states want to be more permissive after that, they can be, but they are not obligated to be. And then should we talk about the healthcare?
Yes, and this is, I think anybody who does any work related to abortion and abortion policy has to love constitutional law just a little bit. So I will let you know that I am not a lawyer, but you mentioned Roe and Casey, and I will mention Gonzalez v. Carhart, which is the origin of this of the specter of what have been termed partial birth abortions, which is not a thing. That is the Gonzalez v. Carhart was a decision that essentially validated the application of a law that described a certain set of events that could happen during an abortion that is not reflective of any reality of the practice of medicine, and gave it this name, and that law was passed and signed. And so no, that is not a procedure that is done. But I think in my mind, where it's important to talk about that is because Gonzalez v. Carhart was essentially a key moment to enable, essentially to lower the barrier to limiting access to abortion, or to lower the barrier for what would pass constitutional muster as a restriction on access to abortion. And so when we see this great influx of abortion restrictions in the 2010s and beyond, a lot of them are referencing the precedent of Gonzalez v. Carhart that enabled the way to restrict access to care. So no, that's not something that reflects actual medical care, but I think the conversation around it is important for the legal precedent and how it helped us to get to the point that we're at right now.
Hi, I was wondering if you could talk about access to medical care, I guess for the Medicaid population. Is there concern, depending on what administration comes in, that there would be even less funding for these procedures?
Sorry, you said access to which procedures?
To abortion for people in the Medicare, Medicaid and Medicare populations.
It's a good question, because federal money already cannot go to abortions because of the Hyde Amendment, which I'm sure many of you here are familiar with, but it essentially says that federal money can't go to abortions. And so not many state Medicaid programs cover abortion already, but those that do it entirely through state funds. So they're largely the places that you would expect it to be. Colorado actually has a measure on their ballot this November to try and get rid of their public funding bans, that they could use state dollars for Medicaid to fund abortions there. I would be surprised if that changes based on a presidential administration, because it's not as if they necessarily have levers over state funds. They control the federal part of the program. But that is an interesting question that I hadn't thought about.
I will say that if you want a very wonky policy advocacy area, I and any other OBGYN you've ever met could talk for a long time about how terrible the job Medicare does in caring for people of reproductive age. Medicare is really, really great for lots and lots of people, but because the Medicare's regulations and statutes didn't really envisage it being used by a large number of people who are of reproductive age, getting things like contraception covered by Medicare, getting pregnancy care covered by Medicare can be outrageously difficult. So it's this very particular gap for people who happen to have Medicare as their insurance, which is a policy problem to be solved.
Hi, thank you so much for this event. I wanted to ask you what you think helps us in terms of not fanning the flames of hate. And in particular, I'm thinking about secrecy. So when I was in medical school and I assisted at an abortion clinic, they would call that clinic a different name. They would pretend it was something else. So there was all this secrecy. When I asked about it, they were like, well, it's really to protect the patients so people don't, picket outside, or the doctors themselves aren't threatened. And then where I live now in Maine, outside the Planned Parenthood office, everyone knows what day the clinic does do them. And there are violently hateful protesters outside trying to shame the heck out of these women as they're trying to go in quietly. And so on the one hand, there's secrecy, and there weren't protesters. And on the other hand, there's not secrecy, and there was all this hate. And I'm a psychiatrist now, and I see the consequence, the mental health consequence of being shown these brutal pictures as you're going in for this vulnerable procedure. So I'm curious, when we think about undue burden, there's also the psychological undue burden of feeling horribly shamed, feeling terribly threatened, feeling frightened. And I'm curious how you think those of us can help lift that preventatively. Is secrecy the only way? But how does that fan shame? I'm curious.
That's a really good question. I don't know that secrecy is the answer either, because I've talked to a lot of people who say that the fact that they can't tell anyone about their abortions, that they have to hide it, adds a feeling of shame. It makes them feel like they're doing something that is wrong. And I imagine that going to a clinic that no one knows what it actually is or what it's called creates a similar feeling. I'm biased because of what I do for a living, but I think that the way that you destigmatize things is you talk about them, and you talk about them a lot, and you talk about them openly and regularly, and you also share facts so that people, it is still always going to be very horrible to see those very misleading images of mangled babies when you walk into an abortion clinic. But if you have been surrounded by people and surrounded by intellectual spaces that treat abortion as a normal part of healthcare and talk about it with accuracy, I think that undermines some of that, and it makes it feel much more normal and far less wrong than the way people have been forced to treat it.
I think too it feels important for me as a cis white man who doesn't have a uterus. I think that's all the more important. That's why I have a sticker on my laptop that says abortion is healthcare, and so when I'm typing on my laptop in the airport, it's just there. I think widening that conversation, as many people as possible being willing to just be totally normal about the fact that, yep, abortion is healthcare and it's part of what we do. And if you need an abortion, I support you. If you need insulin, I support you. If you need citalopram, I support you. If you need an appendectomy, I support you, because I want you to be healthy.
I have a two-part question related to that. Just listening, I realized I have this question, why, this is such a basic question, but are all abortions in abortion clinics, or can any OBGYN who's trained in these surgical procedures do abortions and they're doing them in addition? Because I grew up in rural North Louisiana where there was the one abortion clinic, and you had to go there and travel, 100, 200 miles to get there from East Texas or wherever. So are there OBGYNs who are quietly practicing abortions? My second related question is, I'd love to hear Dr. Brown about your students thinking, students who are training in this care. Do they worry about privacy? Do they worry about safety, especially if they're moving to states like I'm living in North Carolina now that have less tolerance for sure for abortion? So what is their thinking as they're training about personal safety issues?
Yeah. Not all abortions are done in clinics. Many are done in outpatient facilities. Some are done in hospitals. Most abortions are very simple, so they don't need to be done in a very advanced medical setting. It's you take some pills or you have a DNC, which is a very basic procedure. But the reason that we see abortions in clinics so much is because of the effort that was made to stigmatize providing abortions. And so it has been really exiled out of a lot of medical spaces, especially in states that have more stigma around abortion, which is why you see in Louisiana, or you saw in Louisiana, it was largely in clinics. I think it's also worth thinking about hospital consolidation. A lot of hospitals have merged. A lot of them are owned by entities that don't want to provide abortions, for instance, Catholic hospitals. And that also creates a deterrent factor. And so you simply see fewer healthcare institutions that will offer this, even though it is very routine, very simple, and very safe. But I have talked to a lot of doctors in California who do abortion as part of their general outpatient family care.
And there can also be a challenge too. There are a lot of barriers to providing care in those outpatient settings that many of us wouldn't think of until we're at a point of saying, hey, I'd like to do DNCs as part of my outpatient care. Your lease might say you can't do abortions here. Your contract with the hospital that employs you might say you can't do abortions. And if you weren't thinking about it, you might just not have noticed it in the fine print, right? So there are actually a lot of contractual areas where institutions can restrict individuals from providing care, malpractice limitations. None of these things is evidence-based in terms of the safety of the care or who appropriately can provide the care, because we know that abortion can safely be provided by a variety of people with a variety of different training backgrounds and in a variety of settings. But there are a lot of hidden or at least less visible barriers. And then in terms of student experiences, I think it would be hard to think about providing abortion care without having at least some question in your mind about, is this something that's going to be a safety concern for me or my family? But I actually really do think that the primary thing I'm hearing from trainees right now is much more about, well, I'm going to be an OBGYN, I'm going to be a family doc, I'm going to be a primary care doc, and I need this. This is obviously a thing my patients will need. I need to learn how to do it. That's really overwhelmingly what I hear from trainees, more than any concern about safety. I think is incidental, which doesn't mean it's not there or not real, but the obvious thing is, I know I need to provide this care, so I've got to be able to learn it.
Thank you. Thank you.
Well, for sure, we will still be here for a few minutes afterwards. So if folks have other questions or want to speak one-on-one, we'll be here. Thank you very much for joining us. Thank you for coming and for your book.
Thank you. This was so fun.